Okay, and we'll just give it a few more minutes just to let everyone come in. All right, we just turned off the waiting room, so everyone should be allowed in, and we're just gonna give it one more minute or two to let people filter in before we begin.
Again, we're just gonna ask that everybody keep themselves muted and their cameras off, and so that allows the speakers who we have joining us tonight to be spotlighted. And yeah, we'll just give it a couple more minutes.
All right. Ready? Okay, so we will begin. So thank you everyone for joining us for our second session of hopefully many VT Reach sessions. Just a little refresher on what we're about. VT Reach stands for Virtual Teleconference, Reach, Explore, and Aspire to Careers in Healthcare. And so our mission is to really show all different avenues of healthcare and all the wide ranges of professions you can go into. And so today's session is going to feature anesthesiology with Dr. Bridget Marroquin and Karen Clarke, who's a certified anesthesiology assistant. They're both really interesting paths, and we're really excited for you to hear about it. So we'll begin with Dr. Marroquin and her inspiration into medicine.
Hello, thank you, Jillian. Thank you, Lily. I'm delighted to be here this evening. So my path starts like many of our paths in healthcare. My undergraduate degree was from the College of William & Mary in Virginia. And the only reason I went to William & Mary is because I wanted to play golf, and I followed my big sister there. I really had no idea what I wanted to major in or what I wanted to study. But I was attracted to the STEM courses, you know, science, technology, engineering, math. So I took physics as a freshman and barely survived. And then as a sophomore, I decided to take chemistry, and chemistry really spoke to me. I liked the professors. I enjoyed working through chemistry problems much better than I enjoyed writing papers. My roommates were, you know, English major, Russian language major, history major. But I couldn't write papers. So I stuck to the sciences. So as I said, I majored in chemistry, and I didn't know what I was going to do with it, but I was enjoying college. I was college athlete. I was playing golf. Things were going along just fine. And then, you know, somewhere in junior year, some friends of mine were sort of talking about what they were going to do when they grew up with their college degree. And some people were saying, oh, I'm going to be a college professor. And somebody else said, I'm going to go work in some chemical lab. And a couple of my friends said, oh, well, we're going to go to med school. And I thought that sounded kind of neat. I honestly had never considered being a doctor. No one in my family was a doctor, but I thought that sounds interesting. So over Christmas break, I reached out to my family physician and I said, can I shadow you for a few days and see what it is you do? So I followed him around the office for a few days, and I found out that I really liked the detective work involved with being a physician and involved with being a doctor. So, you know, the patient comes in and they have these symptoms, they're complaining of headaches, or they're complaining of belly pain, or they're losing their hair, or they're gaining weight, they're losing weight. And as the physician provider, you can work through those clues and get some more history, get some blood pressure, some vital signs, some labs. And so those are some more clues, and then you can diagnose the problem. So the idea of medicine was still sort of new to me. So in between junior and senior year, I had an opportunity to work in a podiatrist office. So a podiatrist is a foot doctor. They can operate on the foot. They can diagnose problems with the feet. So I worked in her office for the summer, took some x-rays, checked patients in. I did that 3 days a week, and then 2 days a week, I cared for an elderly woman, making sure she got to the grocery store, making sure she got to her doctor's visits, her hair appointments, make sure her meds were organized into her little pill pack. So, you know, as if you decide to go into some healthcare career, you might want to sort of think about shadowing some people, as I did. So by the end of that summer, I was convinced I wanted to go to medicine. So, when I applied to medical school, so in my senior year of college, when I applied to medical school, as I said, this was all new to me. I didn't have any family members or anyone in my family who were physicians. I told myself, and to this day, it still surprises me. I told myself, well, I'm only going to apply once. And if I don't get in, then I will go get a master's in education, and I'll teach chemistry. Either I'll teach high school chemistry or college chemistry. But I'm only going to apply to med school once. And it really wouldn't make sense to me until years later, when I find myself in academic medicine. So I currently, we'll get to that point in my story, but currently I'm a physician, so I take care of patients, but I also teach medical students. I teach residents. So interesting how at the age of 23, I was deciding between being a doctor or being an educator, and now 20 years later, I do both. So kind of a neat part of my story reflecting back on that. So medical school. So I was from the upstate New York. So I went back to New York State, and I went to SUNY Upstate, so State New York University Medical School in Syracuse. So you'll find as you progress through your educational career that state schools are often cheaper than private schools, or if you're an out-of-state resident. So I went to SUNY Syracuse. And when you're in medical school, you know, the first 2 years, if any of you were on the session last month, the first 2 years are a lot of book work, a lot like being in college, but just longer days. And then year 3 and year 4, you're in the hospital, you're rotating with all different kinds of specialties, all different kinds of providers and physicians, and you're really sort of dabbling in all those specialties. And the other really cool thing about Syracuse is I did a extra 10 months of rural medicine. So if any of you are from New York, or you know New York State, I went to Oneonta, which is this tiny little town kind of south of Cooperstown, south of Albany, and I spent 10 months there in my medical school career. So I was the only medical student in this hospital of, you know, 70 staff physicians. So if something cool came in the emergency room and somebody had to go to the operating room to get their appendix out, the surgeons would call me, because I lived right across the street as med students, and say, hey, come on over and scrub in on this appendectomy. Or the emergency room doc would say, hey, I've got this really cool thing. Somebody just sliced their finger. Why don't you come sew it up for me? So that was a little bit of a unique experience for med school. Not everybody gets to do that. So back to sort of the, you know, the med school plan. So I liked everything. I think a lot of medical students really enjoy the clinical world, hopping from one specialty to the other, and learning the providers and what kind of patients come in, and taking care of patients, and learning new things. But the highlight of med school for me was obstetrics and gynecology. So delivering babies, having the opportunity to be on the team delivering babies, is a really cool job. So the moment of human birth is an amazing event, and I think it's a miracle every time. So I fell in love with that specialty. So obstetrics and gynecology, you take care of pregnant women, you deliver babies, you do a little bit of surgery, you see patients in the office, advocate for women's health. So that was my dream job. So after 4 years in Syracuse, I then went to Georgetown University Medical Center in Washington, D.C. And then, so if you choose the specialty of obstetrics and gynecology, you have to do 4 more years of training. But you're pretty much, for those 4 years, you are an MD. People call you doctor. You get a salary, which is cool for the first time in your life. You get a real paycheck. And for 4 years, you learn how to be an obstetrician gynecologist. So I would deliver babies, did a lot of surgery, took care of pregnant women for 4 years. And somewhere around the time of being a resident, I met my husband, who was a surgery resident, and we finished residency at the same time. And then he went off to North Carolina. He went off to Duke to do some extra training to be a transplant surgeon. So I finished residency, followed him there, and worked in rural North Carolina, a tiny little town about 45 minutes north of Duke, delivering babies and taking care of women for 4 years. So about this time, after about 2.5, 3 years as a private practice of obstetrician gynecologist, I realized that I wasn't entirely happy with my job for a couple of reasons. The big reason was I didn't love the office like I thought I would. So being an OB/GYN resident, you spend about 4.5 days a week in the hospital and a half day a week in the clinic in a regular doctor's office. And then once you get out and you're done training, it's almost flip-flop. So you spend about 4.5 days a week in the office seeing patients with sort of not really exciting, terrible things, which is good for the patient, but I was a little bit bored. And babies don't come between the hours of 9 and 5. They come at all kinds of hours in middle of the night and weekends. And being married to a transplant surgeon who was almost never home, we recognized that somebody needed to be home. Somebody needed to be home to be raising those children we were having. So after 4 years as an obstetrician gynecologist, I went back to residency again. So we lived in North Carolina. So I reached out to the University of North Carolina, reached out to Duke. They both had anesthesiology residencies. So I went back to UNC for 3 years of training. So I learned how to care for patients in the hospital when they're having surgery, traumas and emergencies that come in. And as it turns out, labor and delivery, the process of having a baby, is really quite painful and uncomfortable. And about 70% of women request the services of an anesthesiologist to make labor and delivery event more comfortable. So as an anesthesiologist, I could still be part of that obstetric team. I could still be part of that miracle of birth, but just in a different realm. So 3 years of training at University of North Carolina, learn how to be an anesthesiologist. And so because of my prior background as an obstetrician, OB anesthesia is my niche. So after North Carolina, we moved to Rochester, New York, where my husband and I were both on staff at University of Rochester. And then about 7 years ago, we moved here to University of Vermont. So that's sort of how I got to here. So, what's my day look like? So, compared to other specialties, we tend to start our days quite early. So most of us get to the hospital between 6:30 and 7 a.m. in the morning. And we see our patients for the day, and the operating room starts by 7:30. So that means we have to get in, get our operating room set up, get the machine set up, get our medicines set up. So I tell people who are interested in anesthesiology, I love what I do, but I almost never bring my kids to school. So it's an early day. And what sort of things do I do? It sort of depends. As I mentioned, I do a lot of OB anesthesia. So about 50% of my days, I'm up on the labor and delivery ward, which is the 7th floor of the hospital, the most beautiful view in the hospital there in Burlington. Taking care of women who are laboring, or taking care of women who need surgical interventions for their delivery, what's called a cesarean delivery. And, the other things we do, something really simple. Let's say somebody injures their leg or breaks their leg or has a sports injury and they have to have surgery, then we would provide the anesthesia. So they have no recollection of the surgery at all. They don't have any pain or sensation while they're having surgery. And then we turn off the anesthesia medicines we've been giving and wake them up at the end. Sometimes we do things with the gastroenterologist. So those are physicians who take care of the gut and the stomach and the colon. So that's your digestive tract. So if somebody came in, they saw the GI doctor in the office and said, I have belly pain after I eat, every time I eat, I have this awful belly pain. Well, then at some point the GI doctor would want to go in with a camera. A tiny little camera goes all the way down the esophagus and looks in the stomach and see if there's anything going on in the stomach that would cause pain after eating. So if you can imagine, you probably wouldn't want a big camera about the size of your pinky, this long tube with a camera on it going down down the back of your throat, into your esophagus, into your stomach while you're completely awake. So as anesthesia providers, as anesthesiologists, we give patients medicine in a vein, usually in their hand or their arm. So they sort of go off to sleep. They really have no recollection of the procedure. And then we turn that medicine off when the GI doc's done. So it's a really cool job in that, and I'm sure Karen will mention this too, we interact with almost every other provider in the hospital. Radiologists, sometimes radiologists have to do, let's say like an X-ray guided tissue sampling or something. So the radiologist would look with an X-ray and they might see something on somebody's bone and they have to stick a needle in that spot of the bone, right where it's showing up on the X-ray. So once again, that might be uncomfortable for you to be completely awake while they're doing that. So they'll call the anesthesia team and say, can you come give this patient some anesthesia so I can do the radiology assisted procedure. Sometimes we go down to the emergency room and help with some airway things. We we interact with all surgeons, sometimes the pulmonary doctors. So those are the doctors who take care of lungs and take care of breathing. And sort of the same thing. Sometimes people are having issues breathing or issues with lung or bad asthma or things like that. And the pulmonologist wants to take a camera and he or she wants to stick that camera down into your lungs. So similar to the GI doctor, they'll call us and say, I have this procedure scheduled. Can you come take care of the patient such that I can go down and look into the lungs and the patient won't mind and the patient won't have any recall, any memory of the procedure at all. So that's mostly my story, how I got here and what it is I do every day. And I'll pass it over to Karen unless our hosts tell me to do something else.
If you just wanted to talk about your work-life balance a little bit, the average work week for you.
Okay, thanks, Lily, Jillian. So as a full-time anesthesiologist, I'd work about 50 to 60 hours a week. So as I said, we go into work around 6:30, 7 o'clock, and on a typical day, I'll get around 5. So that's, a 10-hour day times 5 days. Because I'm at an academic institution, so a teaching institution, I have 1 full day a week that's dedicated to what we call administrative or educational things. For instance, I might be preparing lectures like a college professor or a high school professor would. I might be preparing lectures for the medical students, or I might be preparing lectures for the residents. So those folks who finished medical school and now they're specializing in anesthesiology. Work-life balance. I think that the new hip word is work-life integration. And I have to tell you a funny story. I was at a conference this past weekend and I was leading a session on resident wellness and burnout. And so one of the slides said something about work-life integration, because that's what we're supposed to call it these days, I guess, instead of work-life balance. And this resident, he was completely, sincere. He zoomed in and raised his hand and he said, Dr. Marroquin, he said, I don't quite understand work-life integration. Does that mean if I bring my laundry into work, someone would do it for me? And I said, that would be amazing. That's an example of work-life integration, but I don't know that any of us have that. So I, compared to being an OB, my days are very predictable. I, go in 6:30, 7 o'clock most mornings, and most days I'm done between 5 and 6 p.m. If I'm scheduled to be what's called a late call person, as the operating rooms, as the surgeons finish, then we get shifted, and those of us who are not scheduled for late will get relieved from the operating room. And so if I'm a scheduled person and I finish my room, I'll get put in another room so one of my colleagues can go home. But it's almost always very predictable. So next week, after spring break, I'll go back to work on Monday, and I know Monday night I'm a late-ish person. So I'll stay till enough rooms have come down that the overnight people can cover it. It's probably once a month for a weekend. I'll be on what's called backup call. So I'll be home over the weekend, but if it gets so busy that the people at the hospital need extra help, they'll call me in. But honestly, I maybe get called in once a year out of those once a month backup schedules. So compared to being an obstetrician who, was delivering babies at this little rural hospital all hours of the day and the night, my life is a little bit more predictable. When I was an obstetrician, we had a live-in nanny. So if I had to go in the middle of the night and deliver some babies and my husband happened to not be home, then someone would be here with the children. But as an anesthesiologist, as I said, my days are predictable. So if I'm an overnight person, I'll go in about 7 p.m. and I'll get off duty at 7 a.m. And that's much easier to schedule. I'll just make sure my husband's not on call that night too. What else? And I have to say, I do love academics. I love the balance of clinical and the educational portion, teaching medical students, teaching residents. And honestly, I think many of times I've looked back and I thought, gosh, if I ended up in academics fresh out of my first residency. So if I got a job at a teaching institution 20 years ago when I finished training as an OB, I bet I would still be an obstetrician. But little rural hospital with not a lot of backup, not a lot of partners to share the call was a little bit much.
Well, thank you so much. And we can now move on to talk about Karen and her journey to becoming a certified anesthesiologist assistant. And we love all the questions in the chat, and we'll be having a Q&A session right after this that will be combined to answer your questions.
Okay, so hi everyone, and thank you Lily and Jillian for inviting me here tonight, and it was great to hear your story, Bridget. I know you well, but now I know you better. So my journey to becoming a CAA or an anesthesiologist assistant, I started off just knowing I was going to go to college, but it was going to be difficult for me to get there. I was, I didn't have the money to pay for it. And it took me a few years of sort of rattling around and traveling and trying to find the right school in a way that I could pay for my way through college. And ultimately, I wound up in Atlanta and going to Georgia State University, and started off as an art major because who wouldn't want to be an art major? And then eventually figured out that was not, you can do art in your off time, but you can't make much money at it. So, but I was good at biology and math and chemistry. So I just started taking those classes because I could get good grades in them, and eventually wound up, I dreamed of going, being a marine biologist, but that wasn't going to happen either. And when I graduated, I, by some miraculous chance, had a pre-med degree, which basically means, I had a biology and math double major and with a chemistry minor. And one of my good friends in school had also been planning to go to med school. And after a couple of years, I thought, well, I can do that. And so I was thinking of I was starting to apply to Morehouse Med School in Atlanta, because they had a sort of a new and exciting family medicine track that they were really pushing. And then I realized how much time that was going to take. And that same friend of mine who was going to go to med school, she had instead gone to the Emory University there in Atlanta and gone there for her master's degree in anesthesia. And I remember the day she said, Karen, you have to do this. It's great. You get a master's degree, it's 2.5 years, and you'll be out, and then you'll have a job and you can work, and you'll still have time to do all the things that you want to be doing otherwise. And then I also met my husband, and it seemed like a reasonable choice at the time to say I could do 2.5 years and be done with that part of my education, or have him sign on to, be there with me all the way from med school through residency. It seemed like a long haul. And I was already getting into my late 20s at that point. So Emory was a perfect option at the time. It was, AA school was interesting. I really enjoyed it. One of the things I really did enjoy was that it's combined, it's sort of joined in a way with not with the med school, although it does function within the med school, but we spent a lot of time with the anesthesiology residents. So we would go to their lectures when we would be in the hospital on rotations. We would spend a lot of time with the residents. And if you had a senior resident, they might be the ones teaching you in the ICU or in one of the specialty rooms. If you were on a cardiac rotation, you might be rotating with one of the senior residents. And so we have a really close working relationship from the very beginning with the anesthesiologists. And then eventually we wind up as a career, you're working, of course, with an anesthesiologist, actually with the whole group. So our skill sets overlap between, the AAs, as we call ourselves, and the anesthesiologists. We do the same procedures. And depending on what hospital you're working at, depends, it can change, it can vary. For example, in the South, down South, it's rare for anesthetists or mid-level practitioners to do spinals and epidurals, whereas in other parts of the country, you're much more likely to do them. Here, in fact, we definitely do them. It varies from practice to practice what procedures we do. But we generally take care of one patient at a time and as a part of the team. So for example, in a team approach of anesthesia, you have an anesthesiologist who is the primary, they're primarily responsible for 2 to 3 patients, and they will go and meet each of the patients. And then there will be an anesthetist who is in each separate room, taking care of one patient at a time. And that anesthesiologist is part of, we're a team. And I look at them as being my consultant. If there's ever any issue, I will call them up and say, hey, can you get in here? We need to talk about this. Or we just plan what we're going to be doing. And sometimes it's just nice to have two sets of hands and two brains to think about what's going on. And so that's basically what we do. And my whole reason for going in to this, going this route was for my personal life. Like I said, had met my husband and was interested in starting a family. And so I wanted to be able to have a time. I wanted more time. And as an anesthetist, generally a full-time week is 40 to 45 hours, maybe up to 50. But we generally at UVM, we work roughly 4 10-hour days a week. And it's generally 7 to 5, sometimes evenings, sometimes weekends, and occasionally overnight. In some practices, we take call. In this particular practice, we don't, we just cover late shifts, and it's pretty regular. It's very predictable, which I value incredibly. And I feel like I've covered a lot of it. This is my favorite quote. Anesthesiology is the purest example of art and science of medicine, because it is precise, but it's also intuitive. So that's where we are.
Thank you so much.
It was great to hear from both of you. And so this is our first Q&A session. So feel free if you have any questions. We have a couple in the chat right now, but feel free to add more as you have questions. So we can start with some for Dr. Marroquin. There's a question that said, would you say that you have more interactions with other providers or with patients in a typical day?
That's a really good question. The short answer is I would say both. So interestingly, some providers or people, or maybe people who aren't even in medicine, when they heard I was going back to anesthesia, they said, "Oh gosh, you'll never talk to patients." But and Karen can probably speak to this too, but it's really interesting. And if any of you on the call have potentially maybe you had your wisdom teeth out, or maybe you showed up in the emergency room and you had appendicitis, and if the surgeon who schedules, let's say you're going to get your hip replaced by the orthopedic surgeon, you probably have seen that surgeon a couple of times in her office planning for this new hip that you're getting, or your grandmother's getting a new hip or something. Your grandmother will have seen this surgeon a couple of times before surgery scheduled, let's say 3 months from now. But then 3 months from now, your grandmother shows up on Monday morning for her surgery. And so Karen and I have to go see her, and in about 10 or 15 minutes time, really get to know her, build a relationship, build rapport, build trust, take her, medical history, her surgical history, what medicines that she's on, what allergies she's on, what is she worried about most about the surgery. We talk about post-op pain. So it's really fast-paced relationship building. So in a given time, if I'm working with Karen, as she said, I'll be covering her room, the room that she's in. She might have 3 or 4 cases with a surgeon, and then there'll be another anesthetist who might have 3 or 4 cases, and then another anesthetist. So as an anesthesia attending, I might be covering all 3 rooms. So then I might meet 9 or 10 patients in a day. And if it's a simple day, there's 1 surgeon in each room. So that's 3 surgeons I'm working with. Sometimes there's 2 surgeons in 1 case, or the first 2 cases are 1 surgeon, and then it switch over. And then we work with nurses, and we work with nurse practitioners and PAs. We bring patients, we pick them up in the pre-op area. So there's pre-op nurses who are getting those patients settled. when patients are done with anesthesia, we bring them out to what's called the post-anesthesia care unit. So now we're transferring these patients over to the nurse who's in the post-anesthesia care unit, that little area where you are for an hour or two before you either go home or you get admitted to the hospital, and then you have your own room. So compared to some other specialties, I think we interact with a number of patients on a given day, and certainly a number of providers. And Karen might have some thoughts on that.
Yeah, no, I always think about it being, short, intimate relationships with people. You're very quickly getting to know someone very well and developing, a rapport with them. And so, yeah, we may, somebody once said to me, "Oh, you must just like having your patients asleep. You don't like interacting with them." And I'm like, it's not really like that. And some of my best days are taking care of people who maybe had spinals and they're awake while their surgery is happening. And so, but they're numb from the waist down. So, I actually spend time talking with them, and I enjoy that. So we have we do build relationships with patients. They're just very short. So, but it's nice. And then, of course, all the other people around, just like, Bridget was saying. So when we all have our favorite surgeons that we like to work with. So.
Another really good question is, what's the difference between a CAA and a nurse anesthetist?
It's a good question. We function the same. So we're both non-physician and, anesthetists. One is, there's just two different paths to get to a similar place, much like physician's assistants and nurse practitioners. So they, do a lot of, just like they do a lot of the same jobs, we function very similarly. So within a practice that hires both, that employs both CAAs and nurse anesthetists, we do the exact same job and are paid the same. So the nurse anesthetists, they take the path through nursing school. So they get their bachelor's degree in nursing, and then they go on and get a master's. And in some programs now, I think they've bumped it up to a doctorate for their anesthesia credentials. And at the end of the day, we do the same jobs. They can, in some circumstances, work under technically as with a surgeon as their supervisor, and so not work within the anesthesia care team model. So that's different, but that's I can't actually speak to that. That's not my profession. But otherwise we're very similar.
Okay, thank you. Another question for both of you is, what would you say your biggest challenge has been on your journey to where you are now, and how did you overcome this?
I can speak to that because it's an interesting piece for me. Is the first question when I was interviewing for the AA program at Emory, the first question that I was asked was, will you be okay not being the boss? So as an AA, I'm not in charge. I have a lot of responsibility. I have a huge amount of responsibility. And at the end of the day, I'm not in charge. And how will I manage that? Because I have the capability, I'm smart, I'm, educated, but it is just the nature of the way we do this, the anesthesia care team. And, for the most part, I work with wonderful people who are respectful, and we have great collaborative relationships, and that's wonderful. But I will say that has been probably my biggest challenge. And gotten through that by making sure that the places I've worked I've been very careful about. I really like where I work, and I really like the people I work with and respect them immensely. So that's mine. But
Thank you
Thank
for
you for
sharing.
that.
Yeah.
So I think for sure the hardest thing for me was to decide to go back and retrain in a completely different residency. So I sort of tell this story like it's, it just sort of happened and it's common, but it's actually quite rare. So, as much as I loved OB, it was just really hard on our family, and I was, exhausted. And as I said, I didn't love the office. I really just wanted a job where I could go in, be busy, deliver babies, or take care of really sick people. And as Karen mentioned on her slide earlier, like use your brain and be completely stimulated, and then go home and just be home, and not have to wait for the beeper or the pager to go off and wonder who's going to watch my kids, or I'm in the middle of something. So that was a tough decision, and I was fortunate enough to marry a spouse to have support. And when we were sort of deciding what I was going to do, and at one point I even considered completely giving up medicine, because I just couldn't see a way out of where I was. And he said to me, honey, as much as blood, sweat, and tears we put into this job, and we all do, no matter what your healthcare profession is, we all do. And I see Karen do it every day, and I see our other colleagues and the other people we work with do it every day. So he said to me, as much blood, sweat, and tears we put into what we do, I want you to be happy. So, you can give it up completely. Or he said, what did you like in med school? So we, I could have also, I didn't mention this, but I could have gone on and done some what's called specialty training, or what's called fellowship training. So, people who do OBGYN residencies then can do an extra 3 years and do like GYN cancers, or high risk OB, or bladder, urogynecology surgery. So those fellowships are all an extra 3 years. But none of them really spoke to me, right? I mean, I wasn't ready to put blood, sweat, and tears into any of them. And he said, well, what did you like in med school? And I said, well, I really liked anesthesiology. And he said, okay. So, he was at Duke and I was at this little rural hospital. And the next day, the program director, the residency director at Duke called me, and we had an hour conversation. And I said to her, am I crazy? Like, and she said, no, there's a lot of people like you. So, I think Karen and I are evidence that anesthesia is a pretty cool job, but anesthesiology is one of those fields that often physicians, then it's their second career. So there's people who do pediatrics first and then find anesthesiology, or they do sometimes surgery for a couple of years, maybe not finish a residency and then switch, or you do internal medicine and then you switch to anesthesiology. So she told me I wasn't crazy. So I, in the next couple of weeks, filled out a paper application and applied there. And then, 8 miles down the road was UNC, and applied there. So that was a really tough time for me, the decision point, but I was fortunate enough to have really good support to help me through that.
Thank you for that. It's a really good story. Another good question we have is, for both of you, what's the most unexpected aspect of anesthesiology, or going into anesthesiology itself?
I think for me, early on, it was the conversations, right?
Mhm.
with the patients, or the
Right.
surgeon, or the patient's mother, or the grandmother, or when you take care of pediatric patients, it's really often the parents that you have to sort of build this quick relationship rapport with, so they trust you taking back their 10-year-old for their tonsillectomy. So that was a pleasant surprise for me. Yeah. And anesthesiology reminded me how much I love the team aspect of healthcare.
Right. I have to agree. I worked, before coming to Vermont, I stayed in Atlanta and worked at Grady Hospital, which is the big trauma hospital in Atlanta. So I spent the first 12 years of my anesthesia career doing working, it's an inner city hospital. It's really hard and rough and sad, and I loved those patients. I absolutely loved them. And I appreciated, and it was hard. We did bad traumas. I've seen things that I would just as soon not, I would unsee them. But that being said, it was incredibly fulfilling, and I appreciated every patient that I had and all of their stories, and knowing that I could be there for them. And just by being kind to them, you could make their day. And they were so appreciative. Not that I need people to appreciate me for what I'm doing. It's just that it was nice. It was a nice environment for me to be in. I enjoyed the patients. And coming here, it's a different environment, and I enjoy these patients as well. But yeah, I think it was surprising to me how important that piece is, how vital.
Wow. Yeah. Thank you. Another question that for you, Karen, is that there were very few CAA programs listed, and I was wondering if you could just talk about why there are so few, or why not every hospital has CAAs. As we know, University of Vermont and the Med Center here does, but I know you've mentioned that not every hospital does, and if you could maybe just talk about that.
Right. So the AA profession is, I mean, it is more than 50 years old. And it started with two programs, one at Emory and the other at Case Western back in the late 60s. Because there was a shortage of anesthesiologists, and the anesthesiologists at the time, there was a group of them who decided they would create basically physician extenders, much like the PAs, the general PAs. And so those two programs were the only programs for probably 30 years. And so there were very few of us. I have license number 200, and it's not that I'm that old. It's just there weren't that many. And so we've grown slowly, but over the last probably 15 years, there's been sort of an explosion of programs. So yes, there aren't many, and we aren't in every state, but there has been a sort of an exponential growth in the past 15 years of programs expanding and going into different states. But each time to go to a different state, there has to be licensure for that. And unfortunately, there is always politics. And people are always feel threatened by their jobs feel threatened. And so often the nurse anesthetists push back against having us come into each state. So each state is kind of a fight. That being said, it's sort of been a slow roll. We keep moving into more places. I moved to Vermont because Vermont happened to pass legislation 17 years ago. And so that's how I wound up here. I don't know if that answers the question. So, and yes, so I know. So why don't more hospitals? Because there's the whole anesthesia care team model. Not every hospital and not every anesthesia department functions under the anesthesia care team. They might just be an all MD practice. which tends to work better in smaller hospitals or private practice. It depends. I mean, it's very variable.
I'm sure we're going to continue to see that grow over the years
Mhm.
to come.
I think so.
We have another question for, I think this was for Dr. Marroquin, but it said you mentioned moving a couple places and that they're curious if this is something normal in the field.
I think we just lost her actually. So
I'm sure she'll come back.
yeah, it might have been a connection problem. So
Well, we figure that out. Another question for you, Karen. Would you say your job is stressful? And is it stressful keeping patients under? What comes with that?
I'd be lying if I said it wasn't stressful at times. What we do is very precise, and it requires an enormous amount of concentration and knowledge and focus. So yes. That being said, every minute is not stressful. There's a saying out there that anesthesia is 99% boredom, balanced by 1% sheer terror. I'm not sure that that's fully true, but there are definitely times when your blood pressure goes up. But for the most part, you become competent in what you do, and competency allows you to be calm and focused, not relaxed, but calm and focused. Is that?
Yes, thank you.
Mhm.
We seem to have lost Dr. Marroquin temporarily. I'm sure she's working
I'll
her hardest
text
to
her.
get back. Yes.
Give her a text.
Let's see.
Anything
We
else?
just give it another minute. Do we have any other good questions? Let's just give it 1 minute to see if she comes back.
sorry, everyone.
And then we can move on to talking about some case studies with Karen and Dr. Marroquin together.
So yeah, they'll move into some interesting cases, and then we will finish off with a second Q&A if there are any questions that you have moving forward.
Or about the cases in general.
So hopefully,
Her text says she was kicked out, coming back.
interesting. Okay.
Um,
The Zoom world we live in.
yeah.
Thank you everyone for being really patient with these technical difficulties.
I can talk to that. So there was a question about AA school while we're waiting on Bridget. So it's a master's program. So you have to have finished your bachelor's degree. And then the first year is heavily didactic. So it's a brutal course load, but balanced then with some your clinical rotations are kind of get fed in gradually in that first year. And then by the second year, it's mostly clinical with rotations that are from two weeks to a month long. And they can be in, generally, we travel from hospital to hospital, often from state to state, getting different rotations in. And then there are also lectures that we have to participate in, and periodic comprehensive exams throughout that second year. And then you graduate and you have to pass the national boards in order to work. Okay.
Well, thank you.
And I sort of got froze out, and here I'm back. But maybe Karen mentioned this. We don't have a CAA school here in Vermont, but we often have students from other AA schools. Did you mention that?
I didn't.
Yeah, so they come and they rotate here. So when Karen was saying, you have some classroom book work, and then after a month or two of that, you travel around the country and you'll do different rotations a month or two here and there. So we often will have other schools send their students here, and so they work with our team. And then sometimes we're fortunate enough to recruit them back when they're done with AA school. So I would say, I'm going to guess like a third of our AAs currently at some point were students here.
Wow.
Oh, wow. I think you're right.
Yeah, let me think about it.
Yeah.
Yeah.
All
Well,
right.
thank you. So we'll move on to talk about some cases that the two of you experienced together, if you want to go into that. And then if anyone has other questions, please just continue to put them in the chat and we'll do another Q&A session after.
I can't think of the last time we worked together.
The vascular room.
Oh, that's right. Oh, that's right.
Yeah.
Oh, yeah. Oh, that was,
I don't remember what we did though.
yeah, I don't either.
Maybe one of the orthopedic rooms with like
Yeah.
Dr. Blankstein or Nate Nelms.
Right. So our days are pretty varied. So trying to remember what I did yesterday. It's complicated. Yeah, so a Blankstein room. Dr. Blankstein is one of the orthopedic surgeons who tends to do total joint replacements. But have we had anything exciting lately? Have you on your own? Without me there?
Probably, right? So, well,
Uh-oh, did Bridget freeze again?
Karen said, oh, the patient could be completely awake and be numb from sort of the waist down. So, we're talking about Dr. Blankstein, who gives people new hips and new knees. Like, maybe your grandmother or somebody, got a new knee or a new hip. So often they'll come into the operating room and we'll wash off their back really, really well with some cleaning soap. And then we feel their spine and we put this tiny little needle in between the bones of their spine and the cerebral spinal fluid, which coats your spinal cord. Maybe you've heard of like a lumbar puncture or a lumbar tap. And so we know we're in the right place because that tiny little needle, there's a little bit of fluid coming back. So we put a medicine in that spinal space. I would say less than a teaspoon of medicine into that space. And then the needle comes out. There's nothing left back there at all. And we lay the patient down and put them on all our monitors. Like, the blood pressure cuff goes off every couple of minutes and we'll watch their EKG and watch their oxygen level in their blood. And within 10 minutes, they are completely numb. They can't move their legs or their feet. And they don't really feel any touch and they don't feel the ouchiness of the scalpel or the surgery. So it is really cool that that kind of medicine, spinal medicine, has been around longer than, when people talk about laughing gas and anesthesia gases, which we use more commonly, but the spinal's been around for a very long time. And that would be the same procedure that we would do if a woman was having a cesarean delivery. So if for some reason the baby had to be cut out of the belly, a woman had to have surgery on her abdomen, we would do that same thing, a tiny little needle into the back, the fluid comes out, we know we're in the right place, give her less than a teaspoon of medicine and she's numb for 2 hours. And she can be completely awake, alert to see her baby being born. So that's really, really kind of a some cool cases we do with spinals.
Right. So more complicated, those are pretty straightforward for the most part. Occasionally we'll have a case that, is someone that we know has perhaps a difficult airway, or they're having some facial surgery. And so we're going to need to get a breathing tube in them. And so we plan ahead, and that's one of those times when it's really great to have the team, because having multiple hands involved is invaluable. And we can, in those cases, we'll talk with the patient, we'll prepare them for what we're planning to do, and hope, and get them off to sleep, and then breathing for them. We have our special instruments that we use to get breathing tubes into people. But those are times that are definitely a team, a team is invaluable. Trying to, right. And then we're able to breathe safely for them. So
I'm looking at this slide here and think of some other cool things we do. So you name a surgery and we are part of the team. So I'm looking at the picture thinking, in the past few weeks, I think we've done 2 or 3 kidney transplants at UVM. So somebody who doesn't have kidney function, and if you don't have kidney function, you have to have something called dialysis. So essentially you go into sort of like a doctor's office 3 to 4 times a week, and they hook you up to a machine, and it's called dialysis. So it takes out all the toxins and the bad chemicals and keeps your electrolytes, your chemistry is kind of like your, the Gatorades that's floating around your body, make sure it's all in balance. And so if you don't have kidneys to do that, you spend 3 or 4 days a week for 3 or 4 hours at a time hooked up to a machine. Unless you're fortunate enough to get on the transplant list, and then they find a kidney match that matches your blood type and matches your immune system, and it gets flown here from somewhere, and the transplant surgeons put it back in. So the surgery itself is really cool, but we can see it over the drape, and we're part of the team and get the patient off to sleep and make sure he or she is breathing well and their blood pressure is stable and the anesthesia is deep enough. And if they, lose blood, we'll transfuse it. If their electrolytes, that Gatorade that's floating around your body is out of whack, we'll replace some of those electrolytes. Yeah.
yeah.
Are there any really memorable cases that either of you would like to speak about that you've had in, it doesn't have to be together, but maybe just in your own careers that you found extremely interesting?
For
Being
me,
part of a triplet delivery a couple of times in my life.
yeah, that's great.
So there's not one patient in the room, but 4, 3 babies and the mom. Yeah.
Wow.
Wicked cool.
And that was a cesarean?
Yes.
Right.
Yeah.
Wow. I remember we had at Grady, it was a really rough trauma, and we really were not sure how this young woman was going to do. And ultimately, after, we took care of her the first day and took her to the ICU, and over the next few days, we kept bringing her back to the operating room and working on her some more. And I remember at the time, because I had, she came in awake and talking to us, and then we got her off to sleep, and then things became very complicated, and there was real question over whether she was going to survive or not. And the fact that she did, I remember when we brought her back for the final operation, and by this time she was awake and talking to us again, and a month had passed at least since she had first come in. And it was so gratifying to be able to talk with her that time, and to have her, she actually, strangely enough, amazingly enough, remembered that first day in the operating room and her first time in, and how she said she had really appreciated that all of us were there for her. And I always think about her. I think about the fact that, she made it, and it was not guaranteed. But she made it, and I will never, I've had a lot of patients that were traumas, and a lot of them made it, but I remember her. For some reason, she was kind of special.
Thank you for that. That is a really good story. Could you guys talk about a little bit about some anesthesia complications that you would deal with ever, if that's something that you encounter?
So we are in the business to avoid complications. We joke, but it's true, like boring is good. We live for takeoffs and landings. So induction of anesthesia, as Karen was describing, we give patients medicine and they stop breathing for themselves. So we put the breathing tube in the airway, which is not always easy. And we hook them up to the ventilator. And then at the end of the case, when the surgeon's done, we've got to sort of reverse all the medicine we gave and wake them up. So that's the takeoff is the anesthesia at the beginning, and the landing is at the end. So airway is a really big thing for us. And I think that the thing we worry about the most, as Karen was describing her story about the lady with the trauma, there's one memorable, there's many, but one of the memorable cases when you talk about complications. So I had a gentleman who came back, he had a hernia, like, so this little weakness in the muscle wall of his belly, of his abdomen, and had to have it taken care of. So one of the anesthesia assistants and myself took the patient back to the operating room, gave him some anesthesia medicines, he's off to sleep. And when we went to put the breathing tube in, it was just, harder than usual, not insurmountable. We eventually did get it in, but a few different tries, a few different tools and toys, and finally got it in. The patient did well. Sent him home, no problem. The next day he called and he had a really sore throat, which sometimes happens from the tube being back there or from multiple attempts. If you think of a sort of, brushing your teeth, brushing your teeth. If you just hit the toothbrush just wrong on your gum, sometimes that can happen sort of in the back of your throat or off to the side, and you get sort of a sore throat, right? You sort of scratch that gum tissue. So he had a really sore throat. And then about 2 weeks later, he called because his dentist said he had some infection, potentially related to the tube sitting back there. And then I had a really long conversation with his dentist, and this gentleman had really prominent, teeth and bony structures in his mouth, more so than the average person. So he ended up being on antibiotics for a couple of weeks. And so, multiple phone calls back and forth to the patient and the dentist. And, I felt horrible about it. And multiple times I'm sure I apologized and said, I'm really sorry you're having this complication. A year later, he came back for either a hip or a knee, I'm not sure, and actually requested that I be his anesthesiologist. I was thinking if it was me and I had multiple conversations with this anesthesia provider or somebody, and there was this complication, I would say, I never want her or him again to take care of me. I want somebody new. But no, he wanted me to take care of him. So little extra added pressure. And I tried to convince him to have a spinal, right? Because that's what almost everybody, I would say 80% of the people who gets new hips and new knees get spinals, unless there's some contraindication, like they're on blood thinners or something. We can't stick a spinal needle in the back, but he just didn't want to. He wanted to go to sleep. And I said, sir, you understand your airway is still the same. You might wake up with a sore throat again. He said, no, Dr. Marroquin, I trust you. So as Karen said, so now it's a patient that I know has what we call a difficult airway, because I've already managed it before. So I had extra people in the room. I had, another anesthesia physician and an anesthesia assistant, and the three of us put him off to sleep and put the tube in fine. But I thought, wow, that's really very kind of you to actually request me. So I think a big part of it was because I kept communicating with him every couple of days, and I did apologize, and complications happen, but he trusted me, so that he has stuck out in my mind.
Oh, yeah.
Okay, that was great. Just another thing I've just started sort of thinking about. It seems like you both normally will, or your most prominent type of anesthesia is general anesthesia when patients seem to be going fully under. Are there like what are certain instances when you would use local anesthesia instead, or do you mostly deal with general anesthesia?
I had a day this week where I worked with one of the ophthalmologists, and it was just, he was doing eye surgery, simple cataracts. And it was local anesthesia all day long. It was kind of a long, boring day for me, thankfully. The reason we're there is because it is possible that when they're tugging on the eye, you can have the heart rate can go down. They want to have one of us there because we know how to handle that. Doesn't happen often, but it happens enough that they're willing to have, to have somebody there. So that's one of those days. It happened to be a very boring day. Everybody did great. And in fact, even a couple of people said, oh, I don't want any sedation at all, because I would give people a little bit of something just to help them not care quite so much about everything. But there were a few people who said, nah, I don't need anything, just the local, which meant that I had nothing to do except watch their monitors and be prepared. So that's it.
We've talked a lot about spinals, right? For surgery on your belly, or for lower extremity surgery, your hips, your knees, your feet. You could have what's called a brachial plexus block. So the nerves come out of your spine and go down your shoulder and go out to your arm. So if you were having elbow surgery or wrist surgery or something, the anesthesiologist or the anesthesia team somebody could put in some local anesthetic up near your shoulder, similar to when you go to the dentist. Sometimes you need local anesthetic for a filling or something. So we can make the whole arm numb for 12, 18, 24 hours, which surgery doesn't last that long. But if you're having shoulder surgery or elbow surgery or wrist or forearm or something, it's nice to go home with a numb arm for, half a day or a day. So you don't need to take so many pain medicines, painkillers, make you loopy, make you sleepy. So we call that a peripheral nerve block. So we do, I would say sports injuries commonly. We'll do some local. Karen talked about ophthalmology.
Even hernias.
Yeah, even hernias, right. The surgeon commonly will put in a lot of medicine around the incision, a lot of local anesthetic, lidocaine, bupivacaine. And as Karen said, we're just up there sort of monitoring the patient, and depending on how sleepy the patient wants to be, we can titrate our intravenous cocktails.
Right.
Yeah. And sometimes we're just there. Sounds like Karen described it. She didn't give anything to some of those patients who are having eye surgery. It's just called monitored anesthesia care. So we are standing by in the room at the head of the patient, just in case.
Just in case.
Yeah.
I was thinking about the nerve block. It's great for 95% or 99% of people, I think. But there are those occasional folks who come along who cannot stand the feeling of their arm or their leg, their limb being numb. And I had a poor woman not long ago who also had a history of opiate abuse and was on Suboxone. And so we had said, a block is what you need. You need to have a block. It'll help you because you can't, the narcotics aren't going to help with pain relief. And then so they did the block, and she was just, the poor thing was miserable. And she said, I don't ever want to have a block again. And so it's the perfect thing until it is not, it's individual. It's so individual. And as much as we try to make, help people make the right decision, it's a challenge sometimes. Those are major challenges that we have. And this, these days, everybody's heard of the opiate abuse epidemic. And it's definitely something that we have to deal with on a daily basis.
So Karen and I are talking a lot about things that go on in the operating room. And certainly I mentioned a fair number of things that we do upstairs in the obstetric care unit and the labor and delivery unit. But as an anesthesiologist, I, could have gone on and done an extra year in a number of specialties, a number of extra fellowships, so an extra year. So we have anesthesiologists who are critical care trained. So they are in the intensive care unit. So when you hear about COVID over the past year and all the critical care doctors and all the patients needing ventilators and needing intubation, needing special intubation teams. So those often are anesthesiologists, those critical care doctors. You can also do an extra year and do pain. So once again, I didn't love the office. I didn't love being in the clinic, but there are anesthesiologists who do an extra year, and that's all they do. Some of them, they are in a regular doctor's office Monday through Friday, seeing patients with chronic pain, managing their chronic pain, doing interventions like nerve blocks for people who have chronic pain. And then you could do an extra year and do pediatrics. So itty bitty babies, neonates, preemies, tiny little babies, and cardiac. So you could do an extra year and be a cardiac anesthesiologist. So you work with the surgeons who do heart transplant, lung transplant, bypass surgery. So that would be a cardiac anesthesiologist.
Well, thank you so much. And then we can move on to just our final Q&A session. So if anyone has any other questions, please put them in the chat. We actually, Dr. Marroquin, there's a comment that says, my partner just reminded me that you were the one who did her epidural last year. She always says that anesthesiologist was her favorite doctor during birth.
Aw.
So that's a fun.
I do feel as though I have the best job in the hospital. And certainly when I'm on labor and delivery,
Yeah.
who does a pregnant lady love more than her obstetrician? Often the anesthesiologist. So it's
Right.
it's a pretty cool job stomping out pain.
It is.
Yeah, so feel free to put any questions if you have them in the chat. We can just give it a little bit for anyone to add any
additional comments. And we can also, if those come up, just do our special thank yous. Again, thank you, Dr. Marroquin and Karen, for being here tonight and for sharing your stories with us, and to the team that helped make this happen. And then we do want to just tell everyone about our next session with Dr. Anne Dixon, who's a pulmonary critical care physician and NIH-funded physician research, as well as Gabe Tharp, who did an MD PhD path, is also an anesthesiologist and a physician researcher. So that will be another great session to attend. And so I will leave the questions up just in case anyone has them, but we want to thank everyone for coming tonight.
Yeah. And as always, this is being recorded and will be on YouTube. If you would like to come back and rewatch this, or if you know someone who couldn't attend the session, it will be on our YouTube channel, which is VT Reach. So definitely join us for our next session, which will be the 4th Thursday in May.
And you're getting lots of thank yous in the chat to both of you.
And maybe someday when we're over this COVID thing, we can have shadowers back in the OR.
Yes.
Yes.
Hopefully that would be really great.
Because that's how I met Jillian.
Yes, I was lucky enough to shadow Dr. Marroquin, and I've loved shadowing anesthesiologists. I feel like they're the chattiest. They're so fun.
We're a chatty crowd.
You get to sit at the head of the patient. I really enjoy that aspect of it.
Mm-hmm. Yeah, we get to watch, like, we're sort of in that bird's eye position, where we get to, when we're not doing anything other than monitoring, we have a lot of time to just sort of watch what's going on and talk to everybody. So it's nice.
Okay, well, it doesn't seem like any questions are coming in, so I think we are good to end it here. Thank you again, everyone, for attending. Thank you, Karen. Thank you, Dr. Marroquin. And this is for our next upcoming session next month. So please attend, tell your friends. It will also be very interesting.
Thanks for
Lily and
inviting me.
Jillian, thank you. Great job.
Yeah,
Thank
thank
you,
you very
everyone.
much.
Have a
This was
great
great.
night.
Thanks,
too.
Karen.
All right. Thanks, Bridget. See you soon.
It's just us, I think.
Yeah,
And my
recording.
dad. Oh, yeah. I think I have to end the session to stop recording. But again, thank
Yeah,
you
thank
so much for
you.
tonight. And we will talk soon.